Okay, yes, we're going to talk about the treatment and prevention related of work-related asthma. In fact, I'm going to try to explain to you mostly a general consideration. Work-related asthma, as I told you this morning, in fact, it's very precise. It's precise medicine because you have different phenotype. And according to these different phenotype, you will give different advices to the patient for the treatment, for the prevention. And also, you need to have in your mind that it's long-term, you have to think about the long-term health and employment outcomes. You are not dealing completely with the patient, you are dealing with a patient, but also with a worker. And this is very important because what you are going to say to him and to the occupational doctor, maybe it's like in French. In France, if I as a pulmonologist, I make the diagnosis of occupational asthma, and I write to the occupational doctor. The occupational doctor decide if the worker is going to stay at his job or not. So it's very important to discuss with the occupational doctor and to discuss with the patient what really he wants to do in the future. So we must be flexible. And I say that because in France, the occupational doctor are not flexible at all. They said, okay, you have occupational asthma, you need to move. And it's a real social problem because, as I told you this morning, for cleaners, all these poor people, now they have no job. And so they become more obese, they smoke more, and they are unhappy, they have depression. So they don't have social role in the society. So it's very important to think what we are going to do when we decided that it's okay, it's occupational asthma. We have very limited study about medication, and I will be back on that. So the workplace intervention, the principle, we want to prevent or to reduce the exposure to the agents. But the key role, also education, is very important because it's the nature of the education. And also you have to think the long-term outcome if the patient remain at the workplace. First, about intervention, you need to ask the patient preference. For many patients, there are a lot of patients who say, no, please, I want to stay to work and to stay at work. I don't want to be out of the job. So you have to discuss with him or with her the anti-asthma treatment, and if they remain employed, the same or reduced exposure, to discuss with the occupational doctor to try to find the right place, the right job exposure to keep the patient at work if it is possible. And you need to find a compromise for a long-term, to avoid a long-term unemployment. So if we try to summarize the factors influencing management of occupational asthma, there are the individual part. So its capability, the ability to work in other roles, which is not so obvious because some people, they are unable to do other things like cleaning, for example. The age, it's not, you won't have the same discussion with a baker, a 50-year-old baker, and a baker, a 30-year-old baker. It's not the same because if he has asthma at the age of 30, it's difficult to keep him in a bakery until 60 or 65 or 70. The duration of employment in current work role, enjoyment of current work role, the financial stability, of course. If he's very poor and you decided that, okay, he's going to get rid of his job, it's a problem. And the patient needs and preferences. And that seems obvious. That seems very general statement, but it's very important, in fact. I say that because now I've been working with occupational asthma, and I realized how important are these stuff. That seems general, but it's very important. About the technical, mostly medical. This is when you are younger, you are very interested in medical stuff. So asthma phenotype, yes, of course. If it is, for example, if it is a severe asthmatic patient, severity of asthma, of course, it's a good reason to ask the patient to try to another job, to control the asthma symptoms. I think it's the first aim. You have in front of you, you have an occupational asthmatic patient. First, you need to control his asthma with the treatment. To have the best, the optimal treatment for the patient. Try to the degree of spirometry that is very important. If you have a very strong airway obstruction without any change after the treatment, it's not a very good prognosis. So also this must be important. Okay, the workplace. Access to occupational health provision. We had discussion about that. If there is no occupational doctor, or if the chairman of the company, they don't care about occupational disease. For example, I gave the same lecture in China. It was a few years ago. They don't care at all about the disease of the workers, completely. I remember there was the guy with the silicosis there, and it was the professor. He said to me, his father had the silicosis. He was working in the mine. They never accept that the silicosis was the consequence of his job, and he died of silicosis without any compensation, without nothing. They don't care at all about that. It's unbelievable. So it depends of the attitude of the employer or the management. The availability and effectiveness of workplace adaptation. Of course, there are some small companies. It's impossible to change of exposure, and that's a real problem. And the sector of employment, the size of the workforce. Of course, if it's a big company, it's easier to change. And the workplace culture. This is also a very important point. All these points are very important, and to keep that in mind when you're. Now, if you look at the control measures, you always think that the mask is the most effective. It's the less effective. Here, RP is the mask. It's the less effective. The most effective is the elimination, and there are very good study published by Olivier Van den Plas in the European Respiratory Journal. They demonstrate clearly that elimination when you have occupational asthma is the best. The problem is that, okay, it's the best at the medical point of view, but at the social point of view, it's maybe not the best. The substitution. Okay, if it is possible, I think it's good. The engineering controls, and for example, substitution, latex, it's the good example. At the beginning of the end of the 90s and the beginning of 2000, there were a lot of latex allergy. We changed the gloves with no powder, and the latex allergy decreased. Training and behavior also could be interesting. So first, you can, for the measurement, it's try to decrease the exposure. This is the limit. This is the limit for the floor dust. It's expressed in milligram, depending of the country. In France, we don't have any limits. To my point of view, it's not very useful because, okay, it's very, if you look at the countries, there are Belgium, there's Finland, Canada, Sweden, okay. But if you close a bakery because of the floor, of the amount of the concentration of the floor in the air, it depends in which period you are. For example, when they are cleaning the bakery, there are a lot of floor dust in the air, but when they are not cleaning, it's less. So it's very difficult because the concentration in the air move a lot during one day. Okay. Examples of workplace control measures in primary prevention. We are talking about Baker's asthma. So the substitution, So level of preventive methods, the type of preventive measures, the workspace sensitizer, and the intervention measures. So you can substitute, it's very difficult in the bakery, but you can develop alternative. For example, use of divider oil instead of flour for dusting tables. You know, all the problem with the bakers that when they are using the flour, for example, they are putting the flour on the bread. And at this time, there are a lot of exposure. For example, for enzyme, because they use enzyme, they have to encapsulate them instead of spreading the enzyme all over the bakery. The engineering controls, ventilation. This is very important because you need to use local exhaust ventilation at the flow release point. You know, when there were waiting station, when there are drought breaks, you understand drought breaks? When la pasta, when they are, and they are also, if you have a ventilation direct above this place, they are less exposed to the floor. Also, the process isolation for all workers, enclosed in silos when dumping floor. And for example, refining mixer leads to reduce exposure, automatization. And it's very interesting because in France, the bakers are very aware about all this problem. And so they do a lot of stuff to decrease the exposure as compared to the hairdresser. The hairdresser, they don't care at all. The people who are working in the hairdresser companies or in salon, they don't care about their employees. It's the opposite in the bakers. The bakers are they are conscious, they are more aware about all this problem. The administrative control, work practice changes for all workers, and use a sieve. You have to train the workers. I don't know how the bakers are trained here. Do they have, there's a school or there are some, what is the training for a baker? Because it's at school that you can train them to sieve, dusting tables, rubbing floor, or for example, the use of vacuum cleaners instead of broom. There is a very old publication demonstrating when they are brooming the bakery, the amount of floor are very, very, very high. It's at this time. And if you ask the patient says, oh, yes, when I'm cleaning, I'm very sick. Education and training for a worker, training on safe work practice. It's easy to say, it's very difficult to realize, yes. And high risk individual focus, the empathies for the training programs. Education on work-related asthma, high risk. I think it's very important for occupational doctors to train and to teach at this time all the young professionals. And then at the end, the personal protective equipment but it's very difficult. When you are a baker, wearing a mask all day long, it's impossible. So they can maybe wearing a mask when they are cleaning or when they are exposed, but all the time, it's very difficult. So respiratory protective equipment, it's the least effective control. There is no large study of long-term outcomes. For some workers, it could be very useful. For example, I have a researcher, and he was allergic to the animals, to the rats and the mouse. So he was wearing a mask as soon as he entered the animal place. He was carrying his mask, and it worked very well for that, but it was very special. If you want not to be exposed to animal allergens, you need to equip the cages with HEPA filter. I don't know if you are familiar with HEPA. HEPA, high efficiency particulate air, and you decrease the exposure. And there are very good control studies demonstrating that you decrease occupational asthma and occupational rhinitis against these animals using these cages. There are English studies. This is now the mask. Now we are familiar with that, the FFP1, FFP2, the cartridge mask, and the respiratory. And this is good, but if you are asthma, it's very difficult to wear. Now the treatment. The treatment, it's not so easy. First, medication, only one study, an old study, 1996. 32 patients. The idea about the treatment, the inhaled corticosteroid, is to know if inhaled corticosteroid is able to decrease the symptoms when you are out of job. They are all these, the 32 patients, they have occupational asthma. They decided to be out of their jobs, and 13 were high molecular weight, 19 low molecular weight, and one group took inhaled corticosteroid and the other not. And in fact, the group with inhaled corticosteroid, they have less non-specific hyperresponsiveness and a better quality of life. This is the only study that we have about medication in occupational asthma. Immunotherapy. This morning, someone asked a question about, or maybe you talk about, there is a Spanish, is Joaquim Sastre. They published a paper on latex allergy. And the people, there are 24 patients, 8 urticaria, 16 rhinitis or asthma. They are proved by skin prick test, specific IgE, methacholine challenge test, and specific inhalation challenge. And 6 months every week injection. And they found that they have an effect on the bronchial asthma. This is A, and no significant effect on rhinitis. This is the only study that we have about desensitization. It was on latex, and latex is less important. There are a smaller study about wheat flour, but it's impossible because there are 9 patients. So it's very difficult to interpret the results. About biotherapy. We published a paper. It was Lavo. Lavo was the first author. We were 10. And it was interesting because if you look at all these patients, one was baker, the other veterinary, farmer, baker, carpenter, dry painter, and rubber walker. So they were exposed to wheat, to cat, to storage mite, rabbit, alternaria, wheat flour, isocyanate, methylene, isocyanate, acrylate. And because these patients, they wanted to stay at work, and also they have severe asthma. So we decided to treat them with omalizumab. And these are the results. You have the inhaled corticosteroid before and after, the number of exacerbation before and after, the oral corticosteroid before and after, and the exposure, the continuing exposure. And if you look at that, you can see that all patients, they were mostly high molecular weight agents, so mostly allergic asthma. So omalizumab, it's normal that omalizumab could be efficient. And if you look at that, it was pretty good results, because 3-4 exacerbation after nothing, 6-1, 4-2, 6-1, 2-0, and no oral corticosteroid after nothing. But also it works for isocyanate, again, which is not low molecular weight, not eosinophilic, not T2. And it's exactly what I showed to you this morning, that even if with isocyanate you have T2 reaction when exposed to isocyanate, and it worked. It worked very well. Look at that. But it didn't work with the acrylate. The acrylate didn't work. So this is the only publication on biotherapy in occupational asthma. So the treatment, first, careful evaluation, ensure that the diagnosis, there is to be really sure about the occupational asthma. Try to minimize as possible the triggering exacerbation. Remember that you are always thinking about, okay, is it an occupational asthma or is it a work-exacerbated asthma? If it is a work-exacerbated asthma, okay, I want to keep it at work. But if I want to keep him at home, I need to decrease the triggering exacerbation. I need try to workplace accommodation away from triggers. That's easy to say, easy to write, but not easy to do. The occasional supplement use of personal protective device. It's exactly. I think masks are very useful for special part of the work, but not a day long. Try to work with even FFP2. I know that because we have a lot. The COVID was very strong in Strasbourg, and as a pulmonologist, my division was 86 bed. We have 60 patients in our. We have COVID, and we are all wearing the FFP2 mask. At the end of the day, you are really tired about the mask. And referral to source and information about relevant social program, and adapt the asthma treatment to obtain a better control. Always the objective, try to control the asthma, try to control the asthma. Work-exacerbated asthma, difference in prognosis, because in occupational asthma, try to remove of exposure as soon as possible when it is severe, when the patient agrees, when there are bad prognosis, that means rhinitis, when there is a severe obstruction. Okay, things to about the removal. With irritant-induced asthma, the patient could continue to work. And this is the idea. The idea is, okay, it's an asthmatic. His asthma is not very well controlled because of trigger. We try to reduce the trigger and we try to control as much. We increase the treatment in order to obtain a good control of the asthma and the patient can stay at work. Compensation. Okay, and I need to ask you because it depends from one country to another. And what I can say for my country, there's a table and all the disease, all the occupational disease are in the table. And if you are, it's pretty easy to be recognized as an occupational asthma, but the compensation is very small. In contrast, in Finland, it's very difficult, but the compensation is very high. For an example, for clinic agents, primary prevention, someone asked me the question, I think this morning, prevention of exposure, complete avoidance, but not always practical. Cause very often not involved in the clinic agents is to try to find the agents. Educations, of course, brochure, video, cleaners, how to store, how to dilute the incompatibility. For example, for cleaners, they used sometimes they mixed the bleach with the acid and then you have chloramine, and this increased the RADS. It's irritant-induced asthma. This is typical. There is I didn't show you because I stopped this morning, but there are some studies from Medina Ramos from Spain. It's a very classical way. Prevention at home at work. Before using a strong irritant product, ammonia, bleach, decreasing spray, could it be replaced first? If necessary, could it be used less frequently and smaller quantities? It's always the problem that the professional, when they clean, they use a lot of stuff, a lot of product, because they want to have the smell, the fragrance. It's, for example, if you visit an hotel, very often in a hotel, you have the fragrance of the product that they use, or even in the bathroom, everywhere. Avoid the use of spray. Spray is terrible. This is avoid mixing exactly what I said, bleach with the toilet cleaners. Rinse the surface after application. Open the windows during cleaning. Active users should avoid staying in the same room immediately after application, because usually they do, for example, all the surface, they forget to open the window, and also they go to the sink, and then they take care about the sink, and so they are exposed for a longer time. It's a problem also to exposure, time of exposure. Conclusion, it is clear that removal is better, particularly in severe occupational asthma. I think it's clear that removal is the best, but decrease also it's very good. But must you not forget, must be practical, flexible, depending of the patient. For work-exacerbated asthma, removal is not mandatory. First thing is to control asthma. Individual protective devices are the less efficient method to control exposure. However, they could be useful for special situations. And this is just about outcome predictors. When you are older, it's not bad, it's a worse outcome. Higher level non-specific hyperresponsiveness, higher level of airway obstruction, longer exposure, high molecular weight agent, and the female gender. I'm not completely sure about that because I don't think we found that. I think it could be related with the wills. I think that's it. Thank you.